have said it in the recording. Okay, that's recording. All right, so what we're going to do, and this is just kind of slightly changing gears a little bit. The side effect lecture is pretty short, and so to save time and to kind of be ahead of the game, I'm going to move anti-angina pharmacology up. It's supposed to be next week. We're going to do it right now. It fits better in with the curriculum, actually, to have it during the same week as the time we talk about STEMI and coronary artery disease, because this was the thing that actually brought the patient into the hospital as of yesterday, if you look at the course outline. And so next week we'll have a leisure time of 2 hours to go through antiarrhythmics. Dr. Shannon will come and help me talk about the various sodium, potassium, and calcium channels, and then we'll look at a pharmacological approach to kind of altering their function. Okay? All right, so angina really kind of goes back to this whole theory of kind of oxygen balance in the heart. And the thing that really brought that patient in yesterday, when we talked about coronary artery disease and ST segment elevation myocardial infarct, was the fact that they experienced chest pain. And that chest pain was so uncomfortable, they sought medical attention. And of course, angina is really the telltale sign that a heart attack is happening. And so some of the drugs that we can use to alleviate the angina symptoms are also some of the drugs that become, I would say, standard of care for the STEMI patient or the acute myocardial infarct patient. Okay? We're ahead of schedule, so don't worry, you didn't miss too much. And so what we're going to do is we're going to kind of alter oxygen supply. We're going to spend a little bit more time looking at some of the vasodilatory drugs today. We've introduced them conceptually, but now we're going to look at them under the lens of treating angina. And really the molecular or the physical target is looking at increasing coronary blood flow. Okay? And so the reason we need to increase coronary blood flow is because the lumen of this particular coronary artery has become more narrow and constricted. And because of its constriction, and that's due to this inflammation, this underlying inflammation, as well as this production of a thrombus, this constriction reduces the amount of blood that's being delivered to the myocardium, okay? And then now, basically, it's becoming under low oxygen conditions, and then in the acute infarct portion, it's recently apoptotic and necrotic. And so you get dramatic cell death, you get ischemia, loss of function, and pain. And that pain is perceived as kind of an accumulation of lactic acid because of altered metabolic states of the cardiac myocytes. Okay, and so this clinical presentation, and this was kind of the introduction to the coronary artery disease STEMI patient yesterday. And so now we're going to kind of freeze frame this and say, okay, we're going to isolate angina or chest pain, angina pectoris, as a specific pathology. And then how do we treat specifically this? And this is, again, due to lack of oxygen because of coronary artery vasoconstriction. And then that perception is perceived as pain. Okay, and so patients who are unfamiliar with the heart attack symptom may take pain relievers because they have tightness in the chest. If they're ill-informed, they would take a pain reliever such as an over-the-counter NSAID to alleviate some of that pain. But in reality, that's not going to do anything. Okay, the only thing that they really should take in terms of NSAIDs would be something like aspirin. All right, ibuprofen and acetaminophen and some of those other drugs, they won't work. Aspirin has been shown in the acute phases of a heart attack, as in like when it's actually happening, to be clinically beneficial. But of course, it's also a function of age too. Not a lot of people in their 40s and 30s and 40s and 50s always have aspirin. It's not really a common anti-inflammatory drug. Most people prefer Tylenol or ibuprofen. Right? And so when the angina occurs, and angina pectoris literally just means chest pain. It's associated with a shortness of breath, profuse sweating, this concept of nausea and vomiting, as well as pain. And the pain or discomfort can go either way. It can radiate down the arm, or it can radiate up the arm and then kind of into the neck and the jaw. Some patients say it'll radiate around the jaw and towards the back. So all those different presentations are equally accountable. Okay, so there's a few different types of angina, and they're classified by kind of what precipitates the condition, and then, of course, how long is it. And so stable angina is if the pain occurs only with exertion, okay, and otherwise the patient's been stable over a long period of time. So this patient would probably be okay just sitting here, but if they had to climb these stairs relatively quickly, they might become short of breath and experience this sharp pain in their chest. This is in contrast to what's termed unstable angina, and this is pain occurring at rest. So just sitting there, their chest hurts, okay, and that's quite uncomfortable. All right. And so if the pain persists without interruption or prolonged periods of time, you can get this myocardial infarct, okay? And so I don't know if you heard yesterday, but when I was 30, I had a heart attack, and that's because I had a right coronary artery physical anomaly that existed at birth, which I wasn't aware of. And so this pain is real sharp, and if you are familiar with anatomy, you can actually visualize the right coronary artery being constricted, okay? To the non-medical or to the novice person, it just feels like nondescript chest pain, specifically right here, okay? And so when they point right there, that's a real good telltale sign that a myocardial infarct is occurring, okay? And then you have to treat soon.
Is that because the sensory nerves like in the chest or in the heart, or is it like that?
There is lactic acid buildup, of course, and then the sensory part does occur because there's an acute kind of inflammatory event, but it does hurt, and it feels kind of like somebody who's really heavy sitting on your chest, or like something that's heavy being pushed on your chest. For those of you who work out and do bench presses, that muscle is very close to where that artery is, and you can kind of feel, but when you're doing chest presses, it would be both muscles, of course. This would be pretty much left side, sternal, and then over. What's interesting is that it also kind of feels like GERD. And so for those of you who have experienced GERD, there's a similar kind of feeling in terms of the anatomy, because it's so close to the esophagus. Again, with GERD, though, you would also experience some pain on the right side as well. And so I've had GERD and angina, and they're very close. We have time. Funny story is a couple of years ago at work, the air conditioner broke, and so they had carted in a big lemonade and a water into the teacher break room. And of course, everybody had drank the water, and I was dying of thirst. My office was literally 95 degrees. And so I had a huge cup of lemonade. And then later that afternoon, I was stuck in traffic, and I have like 0 patience and kind of an anger management problem. And so as I was screaming at traffic, I started to get chest pain again. And so this was 3 years after the heart attack. And so I got scared. I said, oh God, it's coming back. And so I gave myself some nitroglycerin, which we'll talk about in a few minutes, and it alleviated the symptoms immediately. And so I thought, oh God, well maybe this is it. Maybe this is another coronary event. And I went in and got checked, and the EKG was normal. And it actually was GERD. I had literally this, like a 20-ounce or 30-ounce lemonade, and my stomach was just shot. So, GERD. And what was sad was that for a few years before the actual myocardial infarct, I always thought I had GERD, and because I always had this persistent kind of chest pain that would come about randomly. And so I was self-medicating with Nexium and omeprazole and some of those other over-the-counter anti-GERD medications. And then after the heart attack, I realized I've never had GERD, ever, except that one day when I had 80 ounces of lemonade. It was crazy. So, but in terms of the presentation, it's very similar. So if a patient comes in and they says they have chest pain, take them seriously and then hook them up to the EKG. The EKG will tell you if it's normal. If it's normal, then, well, hell, it might be GERD. If it's abnormal, well, now we're dealing with a coronary event, all right? And so the different presentations are depicted here, and you can read these, and I'm sure when you guys go through the pathophys component, you'll discuss these in more detail. what I want to do is I want to talk about the treatment approaches that these different angina types have. And so the other thing that you should know, depending on which book you read and kind of the age of the attending, some people will say typical or stable angina, it's the same thing. Variant or princemetal angina is the same thing. And then unstable or crescendo angina, same thing. So depending on who you read and who you talk to, there's some regional differences, and so they're both there for you to distinguish. Okay, and so the first group of drugs that we'll use for the treatment of angina is going to be vasodilators. Okay, and so these were historically, these are pretty cool. These are the ones that were first used in explosion experiments of Alfred Nobel, and that was kind of like the precursor molecule to dynamite. And so I used to work in pharmacy. We used to tell the new technicians, don't drop the nitroglycerin, it'll explode. And the one guy was, I mean, he was really new. It was like his second day. He dropped a package of nitroglycerin, and my boss and I ducked under the counter, and he didn't know what to do. And that, of course, that is a joke. Nitroglycerin is, in this particular format, is stable. You can drop it, you can throw it across the room, it will not explode. But it was pretty funny watching the look on his face. But mechanistically, what we're going to do is we're going to vasodilate, and we're going to immediately relieve the symptoms of angina by relaxing the smooth muscle. Okay, and so some of the vasodilators, and we had talked about this in a previous lecture, some of them dilate the veins more so than the arteries. But what you're essentially doing is you're kind of, especially on the arterial side, you're kind of opening the release valve. If you think of the heart as kind of like a sink, you know, and if you open the release valve, if you open it all the way, it's like a potent vasodilation. The sink drains very quickly. If you open it half of the way, the sink drains a lot more slower. Okay, but that venodilation or that vasodilation is going to kind of reduce the venous return on the heart, and that's going to decrease cardiac output. What the end result is now the heart doesn't have to work as hard. Okay, because remember, that heart is trying to maintain a specified level of cardiac output that has been deemed appropriate by the body, by perfusion. Okay, and in this case, the heart is really working hard. Okay, and so we don't want it to work any harder. In fact, we would like to make it a little bit easier on the heart. And by making it easier on the heart, by reducing cardiac output, we're actually reducing oxygen demand. Okay, by supplying the vasodilator, we're actually increasing the oxygen supply. So giving the vasodilator offers kind of a twofold mechanistic approach to kind of rescuing the symptoms of angina. All right. And so here's that mechanism. Here you've got your endothelial cells, which are capable of producing nitric oxide. All right. Nitric oxide passively diffuses right into the smooth muscle cells. All right. It activates this guanylyl cyclase, which forms a cyclic GMP. Inactivates myosin light chain, which promotes smooth muscle relaxation. So this is the smooth muscle that's around the vessel. Okay, and when the smooth muscle relaxes, you increase the diameter and you reduce total peripheral resistance. Okay, so you get a nice widening of the vessel itself and then more flow. Okay. With nitroglycerin, you do see a dose-dependent effect on various vessels. Low doses of nitroglycerin preferentially dilate the veins, more so than the arterioles. Repeated doses or higher doses can, again, shift over to the arterial trees and cause those to vasodilate as well. But primarily you get a venous dilation. And so one of the ways in which these vasodilators work, as I said, they're going to reduce the amount of stroke volume or the amount of external work that the heart must endure. And so basically what this does is kind of, this shifts this well-studied left ventricular ejection pressure, ventricular volume curve. And so you guys have all seen these back from physiology, right? I bring it forward because, there was a reason that you had to learn it, and that is to understand some of the pharmacological concepts. And then there's a reason you have to understand the pharmacological concepts is because one day you'll be writing prescriptions, all right? Anybody want to go into cardiology, maybe? Thinking about it? Kind of? I don't know. See how CVS goes? CVS? And so what these vasodilators do, and here's that kind of twofold mechanism that I had talked about, is that they're going to left shift this segment 2, okay, and they're going to downshift segment 3. And so that causes a reduction in the end diastolic volume, all right? And it also reduces the pressure in the left ventricle. And that's, so this end diastolic volume, remember, is associated with preload, so you're going to reduce preload. And the segment 3, which is associated with the, the maximal kind of pressure that the left ventricle undergoes during systole, gets reduced, and so that's associated with afterload. All right, so if you decrease preload and you decrease afterload, you're definitely going to decrease stroke volume because of this parameter, but you're also going to decrease the external work done by the heart. And so now the heart's working a little bit, not as hard as it used to be, and the amount of blood that the heart is receiving in terms of its circulation in the coronary circuitry is increased because there's coronary artery dilation as well. So these nitric oxide donors, or these nitric oxide molecules, reduce both preload and afterload, and that decreases stroke volume. And remember that cardiac output is the product of heart rate times stroke volume. Okay. And this is a nice cartoon that I found online. I think this was from a nursing educational program. Preload essentially is the amount of blood or the volume of blood in the ventricles at the end of diastole. And that's associated with that end diastolic pressure, which you saw in the previous diagram. All right. And so preload gets increased during different physiological changes, so hypervolemia, so when there's too much or volume overload, when there's the regurgitation due to faulty heart valves, as well as in the context of heart failure, which we'll talk about next week. All right. Afterload is the resistance the left ventricle must overcome, and you can see that depicted here. So, in order for this left ventricle to eject a unit volume of blood, it has to push hard enough to go through this vice-like structure here. All right, and so this particular vice-type structure exists in the context of hypertension or potent vasoconstriction. All right. And so then you see an increase in afterload and an increase in cardiac workload. So obviously it takes more energy, more work by the heart to push blood into this compartment if this particular valve is tight, if the afterload resistance is really high. And so what's nice about the vasodilators is that they reduce both of these. So it's easier to put blood in, and it's also easier to get blood out. And if those two processes are easy for the heart to do, it's going to dramatically reduce the amount of work that the heart has to expend to basically maintain normal physiology. And that's how these drugs work. All right. And so there's short-acting drugs, and then there's long-acting drugs. And so the short-acting drugs, the prototype is nitroglycerin, but there's a few others. There's amyl nitrate and then isosorbide dinitrate. The only really difference between these drugs is how they're given. And so nitroglycerin and amyl nitrates are given sublingually. And so this is a tablet, okay, that's placed under the tongue, and it dissolves within a minute or two, and has essentially immediate absorption. And so this is probably the only instance where you can see something that's in tablet form being absorbed in record time. And then if you look at the concentration over time curve, it looks like IV administration. Okay, and that's due to the fact that one, in terms of water, this thing will fall apart immediately when it hits the saliva in your mouth. And then two, there's a rich supply of blood vessels under your tongue and in that compartment of your throat, where any drug or compound that's put in that compartment gets really fast absorption. Okay, and it gets systemic absorption, so it goes right into the bloodstream. There is no going into the GI tract and circulating through, because remember, you're not swallowing this drug. It's not going down the esophagus. It's getting absorbed in that blood that exists under that anatomic compartment. What they've done is they've actually reformulated nitroglycerin, so it even offers faster absorption than what I just said. And that what I just said was like 2 or 3 minutes. Now they make a nitroglycerin spray. It's a sterile spray. Nitroglycerin is dissolved in this liquid. You shake it up and you spray a few sprays underneath your tongue, almost like that that breath freshener that they sell at the pharmacies and the gas stations. It's like Scope or something, and you can spray it in. But this is nitroglycerin, and it offers immediate relief in terms of angina or the presentation of any type of chest pain. And we're talking in like 30 to 40 seconds. It's very fast. Okay. Isosorbide dinitrite can be inhaled, and it can also be given orally, but when it's given orally, there's a small problem that it has extremely high first pass extraction, and so whatever dose you give of this drug orally, if you swallow it, a huge percentage of that dose goes right to the liver, which means it gets biotransformed into something else, and then it doesn't really have systemic vascular effects until much later. So the short-acting ones, it's for good reason. We don't take them orally. They're sublingual or they're inhaled. The long-acting ones have a kind of unique pharmacokinetic properties. Nitroglycerin can also be, it can be given orally, but as I said before, you have to give much, much higher doses than you would normally give, because a huge percentage of that is going to go to the liver, and then a small percentage is eventually going to get to the heart. That takes some time. There is an ointment and a patch that you can use for kind of persistent angina that's predictable, that needs to be addressed over the long term. And then there's isosorbide di and isosorbide mononitrates, which can be given either sublingually or PO. Okay? Question? That's a good question. I don't remember. I don't have a good number comparison, but I can look it up because that's interesting. I don't know if it is 10 to 1 or 100 to 1, but that would make all the difference. I don't know. Okay. Other questions? You know, and so basically I said all this. I said this orally. The patch of the transdermal delivery is kind of for nighttime occurring angina, and so patients that have this angina that wakes them up while they're sleeping, maybe as a consequence of sleep apnea or something, would be really benefited by some type of slow release kind of patch that's over 8 to 12 hours, assuming the transdermal approach. I said all that. Okay, so this is kind of a summary table that I like from Katsung. I just think these are nice because it's all kind of on one slide. When you're reviewing for board exams, you can kind of just look at this slide and it's all there instead of flipping through 4 or 5 different slides. All right, and so the nitrates offer immediate relief quite rapidly, and then they also are going to dilate the coronary artery, and that's going to reduce oxygen demand. Basically, any of these nitrates could be used to target stable or unstable or variant angina. So essentially all 3 forms of the different anginas that exist clinically. Right. The other group of drugs are the calcium channel blockers. Okay, and so now we're going to inhibit calcium entry by inhibiting the pump that's responsible for kind of moving calcium into these cells. Of course, we're looking at the L-type calcium channel, and we're looking at reducing calcium flux through this channel. And these have been therapeutically used for the different types of angina as well as the other heart pathophysiologies we've talked about. We've talked about MI, we've talked about hypertension, and we'll talk about heart failure next week. And so for variant, exertional, and unstable angina, calcium channel blockers offer a really good mechanistic approach. Okay, and they do the same thing that the nitrates do through a different mechanism, of course, but essentially what you're doing is you're kind of opening those veins, okay, causing nice venodilation and a returning of reoxygenated blood to the musculature. In terms of the calcium channel blockers, amlodipine and feldipine, these are really good drugs that offer arterial vasodilation. Nifedipine is really kind of the most potent vasodilator, and in fact, it treats a specific kind of angina that's caused by coronary artery vasospasm. And so this is exactly what this sounds like. The coronary artery, periodically will constrict and dilate, and so, nifedipine will be a really good drug to treat that particular condition. All the calcium channel blockers, regardless of class type, will lower blood pressure, and which is one of the reasons why they were employed in controlling hypertension. Beta blockers, we had talked about the use of these drugs, and by now we've seen beta blockers, ACE inhibitors, calcium channel blockers coming up in all of these different disease states, and it's for good reason because they have these major mechanistic effects. And so beta blockers are going to reduce the severity and the frequency of these angina attacks, both in exertional and unstable angina, and of course we're going to use them post-MI. All right. And it's been shown that when you supply a beta blocker to a patient who has had an MI, survivability is dramatically increased. And the reason is centered kind of on this reduction in myocardial oxygen consumption. All right. One key thing to note about the beta-1 receptor in terms of the pathophysiology of angina is that there's really, in terms of blocking it, only the beta-1 selective antagonists will work for the context of angina. So this scenario refers to the treatment of angina with the beta blocker. Some doctors will combine a beta blocker with a nitrate for the exercise intolerance that patients on beta blocker therapy will kind of complain about. And there's just some other kind of housekeeping notes. You never ever use a beta blocker with intrinsic sympathomimetic activity. So these are the ones that are partial agonists. Those partial agonist beta blockers will actually make angina worse, okay, because they don't offer beta-1 complete constriction, inhibition. They offer some stimulatory effect. And so, the beta-1 partial agonist, you don't see them on any of these lectures that we've been talking about thus far. The other thing is that in terms of patients who are on a beta blocker, either for the management of acute MI or for another indication, if they discontinue the drug abruptly, actually precipitates angina. All right, and so one of the things that you can ask patients who are coming in complaining of chest pain is, did you take a beta blocker? And if you did you discontinue it? And so you never, if you want to discontinue a beta blocker for maybe an allergy reason or an intolerance type issue, you have to slowly taper off their dose over the course of maybe a week or two. And the reason is twofold. One, there's going to be a rebound phenomena in terms of removing that beta blocker from their therapy. And so that rebound phenomenon is going to look like an increased incidence of myocardial infarct, an increased risk of myocardial infarct, an increased incidence of angina. Okay, and the reason is because when you perpetually inhibit a receptor, and this is any receptor in pharmacology, when you perpetually inhibit it for a long time, all right, the tissue's compensatory response is to make more of the receptor. Okay, and so if you remove the beta blocker abruptly, now you're kind of in a worse scenario than you were before, because now you have even more beta-1 receptors than a normal patient. Okay, and so when a bolus of norepinephrine, or even worse, epinephrine comes out because of their exercise or because of their stress, their heart rate will go through the roof. Okay, and that's kind of that rebound effect. And so that's one of the other reasons in terms of beta blockers. You can get acute exacerbations of angina in a patient who discontinued their beta blocker abruptly. You see this a lot of times when the insurance changes and the patient says, the hell with it, I'll just deal with it next week. And then it's a Friday. By Saturday morning, they go to cut the grass and they're in the emergency room with, tachycardia. Right. You also see this in older patients on vacation. They may forget their medication, and so they may come into the emergency room with, extremely high tachycardia, and it's because they missed their dose of metoprolol. All right. So a couple of minor, side things about beta blockers that we need to discuss. So we talked about them. All right. And so this is kind of a nice baseline for looking at treating angina. The problem is that we haven't covered some of the comorbid or concomitant diseases on the left, but this is how you kind of address them. So if there's no underlying disease, it's fine. You can use long-acting nitrates, you can use beta blockers, you can use calcium channel blockers, and this could be or and across the board, okay, depending on the severity and the patient history and so forth. Typically, if they've had angina, they've typically already had another cardiac event, whether it's an arrhythmia, whether it's an MI, whether it's maybe some EKG abnormalities that are indicative of maybe some coronary artery vasospasm. They may already be on one of these for different reasons. They might have underlying hypertension. So it's either, or and across the board. If it's a recent myocardial infarct, it's been shown that long-acting nitrates and beta blockers are more beneficial. We kind of reserve the calcium channel blockers for reasons that we'll discuss next week when we talk about the antiarrhythmics. You don't want to be in too much of a hurry to throw a calcium channel blocker on a recent myocardial infarct patient. Okay, and so you can actually kind of set the patient up for an arrhythmia, okay? And remember, when we had talked about the calcium channel blockers yesterday, we said they're an alternative to beta blocker therapy for patients who are intolerant of beta blockers, okay? That intolerance doesn't really happen overnight. Usually it's kind of a long-term type of thing where, they're stable, and then, after 6 months or 8 months, then you can think about changing them to a calcium channel blocker. But say if the patient has an MI on Tuesday, you wouldn't start thinking about calcium channel blockers on Friday. Your go-to therapy, and actually this is a good time to review, what is your go-to therapies for the recent MI patient that we talked about yesterday? What was yesterday's patient on? Did you guys all have a chance to review the notes, right, or the lecture? First line therapy is ACE inhibitor, right, combined with a beta blocker, combined with a low-dose aspirin, combined with a statin, and probably with one of the P2Y ADP receptor antagonists like clopidogrel or prasugrel, which is Effient. Okay, so that patient's definitely on those. You may want to also consider giving them a nitrate, okay, either a short-acting or a long-acting nitrate, depending on if they've complained of angina post-PCI or post-coronary stent placement. All right, in my heart attack, I hadn't had angina after they removed that bolus or that thrombus. I was fine. I felt like $1 million. I was ready to get out of the hospital like 3 hours later. They didn't let me, but I wanted to. Some patients post-MI, depending on the severity of the infarct, will complain of angina, days, weeks, months afterwards, and it most likely translates to that they have either a really active coronary artery vasoconstriction that still occurs, or there's dramatic ischemia, and oxygen demand and supply still have not been equilibrated even with the drugs. So most MI patients do get some type of vasodilator, some type of nitroglycerin that they take as needed. So if the angina comes back and returns, it's provided for them. I still have the original bottle of nitroglycerin sitting on my nightstand. I haven't touched it since it happened. It's probably expired. It's probably just water by now. Okay. The other thing too is that if the patient has asthma or COPD, notice the beta blocker is kind of removed. And we teach it in the context that, beta 1 on the heart, beta 2 bronchial smooth muscle. Okay. And as some of you have already pointed out in terms of looking at the L-type calcium channel and so forth, yeah, there's beta 2 receptors on the heart. Yeah, there's beta 1 receptors in the smooth muscle. They're much fewer in number. They don't contribute to the overall tone of the organ. But some of these beta blockers are kind of promiscuous, and so even though they are, beta 1, they can also bind to beta 2 at high doses. And so that's where you kind of see, they may not be favored in asthmatic patients in COPD. Doesn't mean they're not used. It just means they're kind of not favored, and so you'll see them in certain textbooks being removed. Okay. The ones that are definitely contraindicated would be something like propranolol, which is a well-documented beta 1, beta 2 antagonist. You definitely would not want to provide propranolol to the asthma COPD patient. If their asthma or their COPD is well controlled, you can probably get away with giving them metoprolol. You'd monitor them initially for the first couple of days, but they would probably be okay. Some physicians would say, well, hell, I won't even deal with the beta 1 receptor. I'll just use the calcium channel blocker. And that's fine too. For the hypertensive patient, the long-acting nitrates, as it's shown here, are kind of less effective. You can see case reports and you can see numerous clinical examples where this would be beneficial. But again, your kind of go-to drug would be the beta blocker or the calcium channel blocker for managing hypertension. Okay. Diabetes, again, there's some indications that, we don't use some of the beta blockers for the diabetic patients. Does that mean you'll never see a diabetic patient on a beta blocker? What does that mean? No, you probably will. And the same can be said with renal disease. And we'll learn about these as we go further. We'll talk about the clinical judgments in terms of when you can and cannot use all these drugs. What is that? I think it's my flash drive too. Nope. So we're almost done. Kind of the new kid on the block in terms of calcium channel blockers and drugs that can alter current is this new kind of drug, Ranolazine. And it blocks intracellular calcium overload, but it does so by not actually blocking the calcium pump or the calcium channel. It actually binds to various sodium and potassium channels. What we see is Ranolazine probably being kind of used for these patients that have stable ischemic heart disease, but are intolerant for whatever reason to beta blockers. And so this kind of gives a different alternative to the pure calcium channel blocking type drugs in that class. We got recent approval. It was approved in USA and Europe. The Canadians still, I think, have not approved this drug just yet. But you'll expect to see clinical trials coming out that look at, is Ranolazine better than the calcium channel blocker in terms of an alternative to beta blockers. There's tons of literature on beta blockers, and there's tons of clinical outcome data on beta blockers, and that's kind of why they're kind of the frontline therapy along with nitroglycerin. Similarly, there's another drug called ivadribine. It's a sodium channel kind of restrictor, but it mechanistically kind of stays at the SA node. We kind of think of this as an antiarrhythmic, and so that's kind of why it goes here as well as in the antiarrhythmic lecture. It is a sodium ion channel blocker, and it's specifically indicated for patients that have stable but chronic angina that are in normal sinus rhythm, okay, who are intolerant to beta blockers. So that's a real specially defined class of patients. It's not your everyday patient. The vast majority of patients are just fine on a beta blocker, but I just want you to know that there are some alternatives that exist once that therapy stops being productive. Okay? And so what I've done was I kind of looked at the different types of angina, and I put the main treatment approaches there. So for typical or stable angina, in the hypertensive patient, you can use kind of a long-acting or slow-release beta blocker or calcium channel blocker. For the patients that have normal blood pressure but do have symptoms of angina, you can use some of those long-acting nitrates. In both groups of these patients, we're probably looking at combination therapy. Most of the clinical trials are looking at, well, if we combine this and this, really it's these two classes. If we combine these two classes, do we reduce the frequency and the severity of the angina episode? And in most cases, we do. The variant with the Prince metal angina, really looking at calcium channel blockers more so than beta blockers. The long-acting nitrates are still employed here. These are the patients that would receive metal stents within the coronary artery as part of the treatment approach. And then the unstable angina, this is your cardiac recent MI patient, ST segment elevated myocardial infarct. And these are the ones that are on all these drugs, aspirin, clopidogrel, or Effient, PCI, angioplasty with a stent, beta blocker, or calcium channel blocker, and nitrates as needed. And so all of these drugs, even though they treat different aspects of the pathophysiology of myocardial infarct, also have utility in terms of combating or reducing the process that produces angina. Okay, so there's another reason to use all those drugs because they're also anti-anginals as well. Good question. Yeah, ibuprofen has the same exact mechanism of action as aspirin in terms of its COX inhibition, okay? But aspirin is more specific for the COX that's associated with the platelet enzyme, with the platelets. And so what happens is that you see a preferential platelet inhibition that's stemming from aspirin therapy that you don't get with the ibuprofen. So in terms of aspirin, our therapeutic target is actually not the COX enzyme itself systemically. It's specifically the COX enzyme on the platelets, okay? Yeah, but the way the dosing works and so forth, aspirin sticks around in the systemic circulation a lot longer than ibuprofen does. Ibuprofen will go into various compartments. Aspirin preferentially, and we don't really quite understand all the kinetics, but aspirin preferentially goes into the platelets and the blood elements. And that's where the bulk of the dose that you give gets deposited. And so, it may be a solubility factor in terms of, aspirin's really water soluble. Ibuprofen is still pretty water soluble, but not that quite. And so there's a tissue specific shunting of the ibuprofen dose. You don't really see that in the aspirin. You see a huge portion of that dose going right into the liquid elements. But good question. That's cool. Okay, let's. Is that it? Yeah. Let's finish with the anti-anginal therapeutics, and then we'll go into the side effect drugs, the side effects of all the drugs that we've talked about.